Thanks, Susan. As mentioned, today we're going to talk about feline hyperthyroidism. And Susan already did a great introduction, but I have some cute pictures of animals and kiddos here. Just a little bit about me. I am currently based in Fort Collins, Colorado. And yeah, we'll go ahead and get started. So hyperthyroidism, this is now the most common endocrine disorder in cats with a prevalence of 10% in geriatric cats. And the most common cause is adenomatous hyperplasia involving one or both glands. Thankfully, only about 1 to 3% of these are carcinomas. And just a little bit of the history of hyperthyroidism. It was first documented by Dr. Mark Peterson in 1979, and then just a year later, he treated the first hyperthyroid cat with radioactive iodine. And after the discovery, recognition of the disease grew quickly. There was an increase in the diagnosis of hyperthyroidism nearly 15-fold in just 6 years. And in one study, and in another study, that it showed that there was a 20-fold increase over about 15 to 20 years. Knowing the history and clinical signs and how to test for thyroid disease has changed how we practice. Routine screening is recommended by the AAFP, now the Feline VMA, and that has helped this cause. So many years of research has been done on the causes. Unfortunately, researchers haven't really been able to pinpoint a specific cause and believe that it's a multifactorial type of etiology. There has been some, evidence that potentially thyroid disruptors that accumulated in the environment or in the food have really affected cats more so than other species because of their unique metabolism. But really, we haven't not been able to identify causation. We also cannot really work towards prevention, unfortunately. So our grumpy cat here says, time to stop talking about history and we'll switch over to some physiology. In the normal cat, we have the pituitary gland that produces thyroid stimulating hormone, which is going to act on the thyroid gland to cause the production and release of thyroid hormones, T3 and T4. Once the circulating concentration of T4 reaches suitable limits, TSH is going to be released from the pituitary and suppress in a classical negative endocrine feedback loop. In the hyperthyroid cat, the thyroid gland is hyperplastic and is autonomously secreting thyroid hormone. The excess thyroid hormone in the bloodstream creates a negative feedback loop in the same way as before, causing TSH production to dwindle to nearly nothing. And then a quick reminder that 99% of the thyroid hormone found in the bloodstream is bound to proteins like thyroid binding protein and albumin, with only 1% free from binding, and this is the biologically active hormone component. Remember that thyroid hormone literally has function all over the body, from heart rate to bone turnover, from digestion to kidney health. It's affecting all body systems. And the mean age of hyperthyroidism is about 13 years old. It's uncommon in cats under 6, but it can be a range of between 4 to 22 years. Typically, we're seeing weight loss despite normal or increased appetite. You can see vomiting and diarrhea, excessive drinking, or hyperactivity and aggression. We can see an enlarged thyroid gland on our physical exam called a thyroid slip. We often see muscle wasting and poor body condition. These cats can sometimes have heart murmur or tachycardia, plus or minus a gallop rhythm. They typically have a matted or unkept coat, and then thickened nails, and then 10 to 20% of them will have hypertension. Typically, hyperthyroidism was diagnosed in cats with significant weight loss and poor body condition. However, as mentioned, with increased recognition of the disease and clinical signs, and physical exam findings might be more subtle. So in the earliest stages of disease, weight loss results mainly from catabolic muscle wasting and not from decreased fat stores. And thus the weight on the scale is not always reflective. So decreased muscle mass is what we want to assess through body condition scoring. Imagine that both these cats here weigh in at a solid 6 kilograms, but when looking at the two cats, the one on the left certainly seems to have a better body condition score. maybe about a 6 out of 9, whereas the one on the right is probably more of a 4 out of 9. And it doesn't matter what scale you use as long as we're consistent, but additional muscle scoring could be useful as well. And then we definitely want to make sure we are doing thyroid palpation because that is really important for detecting that goiter or thyroid slip. There are two different techniques, basically a 1 finger and a 2 finger. The first is the classic palpation where the cat's neck is slightly extended and the head tilted backwards. You take your thumb and your index finger and pass it over both sides of the trachea, starting at the laryngeal area and moving towards the thoracic inlet. And then the second technique, called the Norsworthy, is where you're standing behind the cat with the cat's head raised and turned to kind of a 45-degree angle away from the side. And then take the tip of an index finger, place it in the groove formed by the trachea and the sternothyroid muscle just below the larynx and move downward in the groove towards the thoracic inlet. It's important to remember that you should start at the larynx and fall all the way down to the thoracic inlet because the thyroid gland can migrate, so it might not always be in the same spot. Remembering to palpate for the thyroid gland is really important because we want to palpate every cat, young and old. You'll start to appreciate what's normal and what's not, and it gives us another piece of the puzzle, especially in our gray zone cats, which we'll talk about. It's a 2-second test. It can give you a lot of support to the right direction of diagnostic suspicion. And remember that not being able to palpate a thyroid nodule doesn't necessarily mean that you should suspect hyperthyroidism any less. Thyroid tissue can migrate and even be into the thoracic inlet and be somewhat difficult to feel. Not all cats with hyperthyroidism are going to have cervical masses, and plenty of cats with cervical masses do not have hyperthyroidism, as seen in this quote from a study here. All right, so now we have to take a blood sample, and oftentimes these kitties are not feeling well, and this is combined with hyperactivity and restlessness, and that can make them cranky. And of course, these are the ones we have to get blood from. So let's talk about what we're going to do with that blood sample once we extract the blood from the cat, and hopefully we haven't given any blood of our own. So we want to do a minimum database. This is crucial because we're dealing with a geriatric population that is very likely to have a few metabolic or other disease conditions going on at once. We want to include a thyroid test, obviously, in our panel, not only to give information on the thyroid function, but helping create an overall picture of the cat's health. And it's important to remember that the currently available tests of thyroid function include total T4, free T4, which can be measured by equilibrium dialysis or other measures, and then canine TSH, and we'll talk about feline specific TSH as well. In cats, there's little on routine lab work that specifically indicates hyperthyroidism. The CBC can be quite variable. Because thyroid hormone influences the production of erythropoietin, they might have mild polycythemia, although concurrent illness can predispose to anemia of chronic disease. On chemistry, azotemia can be variable, although importantly, 85% of hyperthyroid cats are going to have a mild to moderate ALT elevation. This can occur with or without ALP elevation as well, which is only seen about 60% of the time. Urinalysis, while important for full workup, can also be pretty variable. Interestingly, despite PUPD, a lot of these cats remain able to concentrate their urine to over 1035. Proteinuria is found in about 3 to 4 of the cases, but typically will resolve with treatment. And we also have to keep in mind that we are dealing with this geriatric population. Other disease conditions are common, and those other diseases, which we call non-thyroidal illness, are going to affect our lab work results. And this is true of our minimum database, but also it's true of our thyroid testing. So while we know that about 90% of cats can be diagnosed hyperthyroid by the combination of clinical signs and an elevated T4, there is a small percentage of cats who are falsely diagnosed hyperthyroid on the basis of an elevated T4 alone, and not all cats with hyperthyroidism will have an elevated total T4, especially in early phases of the disease. Several factors weigh in when we consider cats that look and act hyperthyroid but have a normal T4, such as the stage of the disease, early disease, the values may not be elevated yet, Normal fluctuations in T4 hormone may go in and out of the reference range if it's borderline, and then non-thyroidal illness can take a thyroid value that's actually elevated and lower it into that normal range. And so we can celebrate if we have an elevated T4 and, compatible clinical signs. We feel great about that, and we can make a clear diagnosis and offer an uncomplicated treatment. But what if we don't have a clearly diagnostic T4 value? So the 2016 AAFP was what it was called back then, guidelines for management of hyperthyroid, helps clear up some of the mystery behind the cases that are not so clear cut. It organizes these cats into 6 clear categories and then gives us guidelines on what to do with those groups. So group 1 is our classic hyperthyroid cats. Our group 2 is possible hyperthyroid with probable non-thyroidal illness. So normal T4 could be from early disease or secondary to non-thyroidal illness effect on thyroid hormone levels. Group 3, we have an enlarged thyroid gland, but no signs of hyperthyroid at this point. Then group 4, we have subclinical hyperthyroidism, where we have an elevated T4, but very few, if any, clinical signs. Our group 5 is going to have clinical hyperthyroidism with 1 or more concurrent non-thyroidal diseases. And then group 6, you have clinically normal cats with just an increased T4. And here you can see that in a majority of these cases, the next step is either to repeat a total T4 or to perform additional thyroid hormone testing in the form of TSH to help confirm or exclude hyperthyroidism. And remember that none of the treatments for hyperthyroidism are benign, so we want to be sure of our diagnosis before we're proceeding straight to treatment. We'll talk a little bit about free T4. Traditionally, we've used this to support the diagnosis of hyperthyroidism in cats, although you may have noticed that free T4 wasn't listed as part of the next step in workup in cats. As a reminder, free T4 is only measuring thyroxine not bound to protein, and therefore is a more sensitive test than just our T4 alone. In fact, when the equilibrium dialysis methods use, the sensitivity is nearly 99%, meaning that with 99% confidence, hyperthyroidism can be ruled out. However, these very sensitive tests shouldn't really be used to confirm a diagnosis. The best example of this is like with our highly sensitive cortisol levels, which we're using to rule out Addison's, but not necessarily to diagnose it. And research has shown that the free T4 could be normal, increased, or decreased in cats with non-thyroidal illness, and therefore a free T4 measurement, no matter how we're obtaining it, whether it's equilibrium dialysis or not, shouldn't be our sole test to confirm hyperthyroidism. Radioimmunoassay is kind of being phased out due to safety issues and cost associated with maintaining radioactive substances. That was a traditional method. Equilibrium dialysis is becoming less routinely available, and now you have to make a definitive request for this. It takes longer than some of the other methodologies. And it's important to know that there's many different assays available, though only one of these newer methodologies has been evaluated in cats with hyperthyroidism. That's the Siemens Immulite 2000 chemiluminescent test. And there have been a few studies comparing this chemiluminescent method that have shown good correlation to reference methods, including our RIA and ED. However, the accuracy is still somewhat questionable because the method appears to consistently undervalue results when compared to equilibrium dialysis by a range of almost 5 parts mole per liter. This questionable accuracy has resulted in the recommendation that we not use this for monitoring our hyperthyroid cats following their radioactive iodine therapy. Finally, none of the studies thus far have evaluated the potential impact of our non-thyroidal illness cats, which we know is somewhat common. So free T4 is not always the best option, especially when we have non-thyroidal illness. What additional testing can we do? And that's where thyroid stimulating hormone comes in. In human medicine, serum TSH is the most important thyroid hormone when they're testing for this. In veterinary medicine, it's only been fairly recently that canine TSH was developed, and although evaluation of the usefulness of canine TSH for both cats and dogs has been performed, its potential diagnostic utility in cats has not become yet common knowledge. Remember, going back to how TSH is secreted from the pituitary where it acts on the thyroid gland, it's going to increase circulating thyroid hormone. A classic endocrine negative feedback loop is going to occur where TSH secretion is decreased in response to increased circulating thyroid hormone levels. And in this negative feedback system, the effector molecule also serves as the breaker, the shutoff system, to shutoff switch to the system. When excess T3 and T4 are available, they are going to directly inhibit this release of TSH. In the case of hyperthyroidism, the thyroid hormones are being autonomously secreted, and the excess thyroid hormone is going to negatively impact the system, resulting in decreased levels of TSH. In fact, TSH levels compatible with hyperthyroidism in cats have been shown to be below the lower limit of quantification in our currently commercially available canine TSH assay. So we have the canine version of the TSH test, and remember in vet school we learned that a cat is not a small dog, and it's once again true with this test. The canine assays, many of these are repurposed human assays actually, do not have a lower limit of quantification that can even get into the normal low levels of TSH that cats can have. Because the thyroid hormone has such a suppressive effect on the TSH, these cats in a disease state often have values super, super close to zero. But more importantly, the normal range for TSH in cats is often lower than the current assay's lower limit of quantification. But interestingly, an early study showed that when you see results of this canine TSH lower than the detectable limit, this could be helpful in predicting future development of hyperthyroidism in cats. And further study performed by Mark Peterson's group concluded after looking at over 1,000 cats that nearly all of the cats had a canine TSH level too low to measure, meaning that the finding of a measurable TSH, canine TSH, could be used as a sensitive screening test to help rule out hyperthyroidism in cats. Unfortunately, this canine TSH could not reliably differentiate between normal healthy cats and those with non-thyroidal illness, and it can't be used as a sole diagnostic test. A more recent study by Mark Peterson's group wanted to continue to evaluate this question of how do we differentiate between healthy and non-thyroidal illness cats. So looking at the thyroid hormone patterns of 222 cats with non-thyroidal illness, and then 380 clinically normal cats. And you can see here that the serum T4 decreases with the severity of non-thyroidal illness from mild to moderate to severe. The free T4 has a slight trend towards decreasing. However, in general, there was much more variability, and statistical significance was most impactful from mild to severe, with less clear distinction in that middle area. And finally, you can see that the serum TSH measurements, this is canine TSH, even though that's not an excellent marker for feline hyperthyroidism, you can see there's much more consistency, less variability in that TSH in the face of non-thyroidal illness. And as Dr. Peterson said himself, all of these commonly used tests have limitations, especially when we're evaluating cats suffering from non-thyroidal illness. Clearly, we still do not have the perfect thyroid test capable of both confirming the diagnosis of thyroid disease in all affected cats and completely excluding it in cats that do not have thyroid disease. So what now? What do we do? So Zomedica has developed a feline verified TSH test, which has been integrated into point of care diagnostic system, allowing for these test results within 20 minutes. The lower limit of detection of this assay is actually 0.008 nanograms per mil compared to the lower limit of the currently available TSH, which is 0.03 nanograms per mil. So we're talking about the difference between nanograms and picograms as far as diagnostic sensitivity and increased diagnostic sensitivity in this very important low range, which should, we believe, allow for better characterization of the feline thyroid patient and allow for differentiation of these hyperthyroid from normal thyroid and euthyroid sick cats. So with all of this important background, let's look at some of the data from this feline test. We have results from Truforma feline TSH in cats with clinical hyperthyroidism compared to euthyroid cats. And we have a total of 170 feline samples, 110 normal and 60 hyperthyroid cats. And we see there's a pretty clear-cut distinction or clustering within the groups. The green line there is the lower limit of quantification of Truforma, which is that 0.008 nanograms per deciliter. And the orange line is the lower limit of detection for the canine TSH, that 0.03. And then the y-axis is scaled, meaning here's 0.01, the next up is 0.02, then 0.03, and it's stretched out in this way in order to allow us to actually see the distinction between the data points. And what we see here is that there's a population of normal cats that are at or below that lower limit of detection in the canine TSH, although none were below the limits of the Truforma feline TSH. In the hyperthyroid group, values are reported out lower than 0.008 nanograms per deciliter. They're for research purposes only, as we know that values below the limit of quantification lack precision. And then getting into a little more data from the Truforma, when we talk about precision, we're talking about how similar repeated results are to one another. And so we have our precision data where we evaluated multiple tests run on the same sample using different machines. And the graph is representing the coefficient of variation, which is established, calculated measure to show the level of precision over 3 serum samples. Each sample was tested with 5 replicates on 3 separate days on 2 different instruments for a total of 90 runs. And all 3 samples had a percent of variability less than 10%, showing a high level of repeatability on one instrument and across 2 different instruments. Industry standards for precision are to have a CV of less than 25%, so it is significantly lower than that. And here's some correlation data showing how the Truforma feline TSH compares to the canine TSH, because the researchers wanted to make sure that the assay performs well at this low end of the range. The correlation data was collected using diluted samples of known concentrations of TSH. So we have very high correlation in the 90s compared, when you're comparing the 2 assays. And why does this matter? So here's the same graph of the data. We have the lower limit of quantifications for both of the tests. And also here we have our line of 0.01 nanograms per deciliter. And this is, again, the total of 170 samples. 95% of the clinically healthy cats had a serum TSH above that 0.01 nanograms per mil, where 93% of hyperthyroid cats had the TSH below that 0.01 nanograms per mil. So if the normal cats, 12% had a TSH level below the limit of quantification of the canine assay, but above that 0.01 nanograms per mil. And these are cats that could have been falsely diagnosed with hyperthyroidism on the basis of that diagnostic test lacking enough sensitivity in that low range. And this allows us to say that because of the enhanced sensitivity and improved detection limits of the Truforma assay, the serum TSH concentration can be utilized to help distinguish between those normal and the hyperthyroid cats. And the most likely current candidate for that cutoff is a serum TSH of 0.01 nanograms per deciliter. So that's where we put our unit of our lower end of our reference range. So while it's unlikely that feline TSH will replace the need for total T4, the combination of T4 and feline TSH is likely to replace the free T4 combination in cats during workup for hyperthyroidism. And there's significant value to using the combination of T4 and feline TSH in your routine preventative care, diagnosis, and potentially also in monitoring for cats being treated for hyperthyroidism. So what about some other potential applications other than diagnosis for feline TSH in practice? So monitoring during and post-treatment is another huge application for the feline TSH assay. Most importantly, monitoring for idiopathic hypothyroidism, which is likely to be far more common than we recognize, regardless of the treatment that we're using for hyperthyroidism, whether it's radioactive iodine, oral methimazole, surgery. Hypothyroidism is going to occur in nearly 1 out of every 2 cases. And pitfalls in our ability to recognize the iatrogenic hypothyroid cases include that the clinical signs are not easily appreciated. Often it seems like they're just getting better, or they're written off as associated with a concurrent non-thyroidal illness or aging. However, in one report, it was indicated that by monitoring with T4 alone, nearly 80% of cases of idiopathic hyperthyroidism could be missed. Why does it matter? Well, unfortunately, studies have shown that iatrogenic hypothyroidism is associated with decreased GFR and azotemic chronic kidney disease in cats that are treated with hyperthyroidism. Further, cats that were azotemic secondary to iatrogenic hyperthyroidism had a significantly shorter median survival time, that is 1/2 as long as the cats who did not become azotemic. Initial studies into whether correcting the idiopathic hypothyroid state improved survival time were supportive, but not confirmatory, with improved creatinine in all cats studied and resolution of azotemia in 50% of the cases. But the reason why the data might not seem as compelling is most likely because SDMA is going to be a better indicator of GFR in these hyperthyroid cats than creatinine due to the major changes in their muscle condition that occur in the disease state and with treatment. The point is, hypothyroidism happens and likely happens more often than we realize, and many cats become transiently hypothyroid post-treatment with I-131 as a normal part of this healing process. However, given that we know even subclinical hypothyroidism is going to decrease GFR in people and in dogs, it may be that we are simply not doing enough to monitor for this phenomenon. So the feline TSH is likely to be very helpful here. First, if a pet is azotemic, then finding a low or low normal T4 in combination with an elevated TSH suggests that at least part of the azotemia is secondary to iatrogenic hypothyroidism. In cases being treated with oral methimazole, we should be decreasing dosage in that case, and in cases being treated more definitively with I-131, it is actually indicated to give them some oral thyroid supplementation. Importantly, the feline TSH must be interpreted in combination with the T4 because the TSH has shown to be increased in cats with even normal T4 levels. And then the very last study we're going to talk about today, this was a recent one published by Dr. Peterson in the American Journal of Veterinary Research just last year. And this study compared the feline optimized TSH assay with the chemiluminescent canine TSH assay. And this showed superior sensitivity and specificity for the feline optimized test. And the nice thing about this study is it really evaluated many different groups, including hyperthyroid, radioiodine treated, chronic kidney disease, as well as healthy cats. And so the clinical applications here that he concluded were that the bulk acoustic wave assay is going to improve diagnosis of subclinical and mild hyperthyroidism, which is going to aid in veterinary clinical decisions in cases where we can't do scintigraphy, which not everyone has that available to them. And obviously, this is a little less invasive and less time consuming and less costly for owners than scintigraphy. So hopefully there is more to come. I feel like I spoke really, really quickly, but that is all we have. And this is, a fairly new development in feline medicine. I'm really excited to see what else can come out of it in terms of how we can help these cats. I think that it's going to become the new standard of care in terms of, diagnosing and treating these cats sooner. I think, in the past, it's great that we have, in some cases, this high thyroid that is indicative of disease in a very straightforward case. But I think more and more we're going to be finding this disease earlier on in these subclinical cases, and we're going to be able to help more cats before they get organ damage and other bad things from this disease. So that is what I've got for you today. Feel free to reach out with any questions via email.